nobody's root for the Chiefs this weekend, are they? You guys are probably like, wait, Super Bowl? What are you talking about? I didn't even know there was a Super Bowl. All right, well, we're going to talk about thoracic surgery today. We're going to go through quite a bit. There's a lot involved here, but we'll look at, chest x-rays, we'll evaluate pleural effusions, pneumothorax, infiltrates, and then we'll look at some of the, diagnostic and therapeutic treatments we do for those, and we'll discuss these procedures. But it's important to talk about the anatomy here in the chest. So the chest is, it has a lot of complicated structures in it. It's important that we understand the physiology of the rest, our respiration for it. So obviously we have our thoracic cavity, which is protected by the ribs, and inside of there we have a lot of vital structures. So it's important to understand how respiration works in the lungs when, our diaphragm contracts and we take in air. And we like to separate the chest into the different compartments, so we call it the mediastinum. And there's a couple different ways that people discuss it. We're going to talk about the three-compartment method here for us. And then it's also important to understand that we have a pleural cavity in there, and that pleural cavity has lining in it that can sometimes cause some problems that we're going to discuss here. So the chest wall is lined, so we have that pleural membrane, and it's divided into the parietal pleura, which is the innermost lining on the chest wall, and the visceral pleura, which covers the lungs and joins at the hilum. And this is important because we can get a lot, the disease processes we're going to talk about today, they can affect some of the pressures in those areas, or inflammation in those areas can cause some problems that we have to diagnose and treat. So the mediastinum, we separated into the anterior, posterior, and then the middle mediastinum. And then we have quite a few different structures located in there. In the anterior, we've got our thymus gland, lymph nodes, we've got the ascending aorta, and they transverse. And then we separate into the middle, which has the heart, the pericardium, the trachea, the hyla, the lungs, and then we have some nerves and lymph nodes in there as well. And then we have the posterior mediastinum, which contains like our sympathetic chains, vagus nerve, esophagus, thoracic duct, and lymph nodes. And this is important because when we have some of these disease processes, especially malignancy, or any sort of nodules in there, depending on where they're located, they can cause compression in those areas, which is going to then require, it'll kind of guide our symptomatology, where we think the lesion is and how we diagnose it, and then ultimately what the treatment's going to be. And we also have like our different pressures in here, which we won't get into. Like we have, on the upper right here, we have our capillaries, and we have our lung, chest wall, and our pleural space. And we've got our osmotic pressures and hydrostatic pressures. So we won't get into the details and the numbers of it, but basically the bottom line is it is a net neutral, so we don't have any movement of fluid in and out of there. Typically only a few milliliters, like 3 to 5 milliliters are in the pleura, or pleural space. So we'll talk about what diseases affect those and why it will be important in the next few slides. So some of the diagnostic studies we use, and some of them are looking for certain bacteria. We also look at some fungal infections as well. So we do some skin tests like for tuberculosis. Have you guys all gotten the PPD in here? I'm sure you guys have. Yeah. So we do some screening tests for those. You can do one for histoplasmosis as well that's similar to like a PPD. But for coccidio, and usually for histo now we use a PCR. A little bit better test, but you can still skin test it. We're going to talk about endoscopy. So everybody know what laryngoscopy is? When we use a laryngoscope and we can look at the vocal cords, like when we're intubating a patient. So another way we can just assess this without actually using the laryngoscope is we use a little fiber optic scope that we can place down through the nasopharynx. You can also place it, through the oropharynx, but it's a lot more comfortable to place it through the nasopharynx. A lot of you guys will do this during your HE and T rotations when you're out there in phase 2. So it's basically just, we put a little bit of numbing agent in there and we place a camera down, usually through the nasal passages, and then we can actually assess and look at the vocal cords, and we can look for movement of the vocal cords or any lesions that might be on there. So it's basically a scope that we can use. bronchoscopy is done the same way. So you can go through the nasopharynx, or you can go through the oropharynx, and you're basically using a scope all the way down into the lungs, so it's basically just a longer scope. These are minimally invasive. We can usually, like the laryngoscopy, we can do it without any sort of anesthetic, just local anesthetic in the nose with lidocaine. And then for the bronchoscopy, they might require mild anesthesia, but a lot of times, if we can numb it up well, we can keep them completely awake for these procedures. So it's important that we understand the differences between those. And then we also have like mediastinoscopy, which is basically an incision, and we place a camera somewhere in the mediastinum. And this is what our mainstay for evaluating the mediastinum. So like a lot of times we'll use it to sample lymph nodes in those areas, especially when it's secondary to lung cancer, which we'll talk about. And then we just have different techniques for the mediastinoscopy, whether it's cervical or anterior, and what we're doing. The video, we also have what we call VATS, which is video-assisted thoracoscopic surgery. So remember how we talked about laparoscopy in the belly, where we place some cameras in there and we don't have to actually use an open incision? So it's almost the same thing except for the chest. We can make a small incision, we can place our scopes in there, and we can evaluate and do surgery through those instead of having to do what we call thoracotomy, which is opening up the entire chest. And we'll have some pictures here in a second to show that. And then we also have multiple biopsy techniques, which we'll get into on some of the following slides. So we have needle biopsy, which is the most common indication for a solitary pulmonary nodule. And you guys will see this a lot. So you'll get chest x-rays quite frequently in your clinics, and you'll have incidental findings, and it'll be a pulmonary nodule, and you'll say, oh man, what do I do with that? So we'll talk about some of the criteria for it later in the slides when we're looking at nodules. But it will a lot of times be an incidental finding, and then we have to decide whether we need to do a biopsy on it to assess it further. And we'll go over the criteria we use, basically your typical criteria for looking at any mass. If you're looking at like whether it's spiculated, whether it's whether the margins are well rounded. There's all kinds of criteria we'll talk about. We'll talk about sizing and when we need to get those studies. We also do sputum analysis. So this can help with lung cancer. It can also help with some of those other conditions, like tuberculosis and other things like that. We can get the sample from deep coughing. A lot of times we don't get enough sputum or deep enough sputum to actually diagnose anything. So a great way to do we do the sputum analysis a lot of times with a bronchoscope, and we'll place it down in the lungs, and we'll either basically scrape the side with a brush, or we'll just put some saline in there and do a wash, and then we'll run the sample from that. So that's another option we have. And then for all of the chest pathology, we typically start with the chest x-ray, but a CT is a great test, and that's typically the next in our evaluation, the cornerstone for chest pathology. So a lot of times when you find these incidental lesions on your chest x-rays, you'll order a CT just to get a better idea of how large it is, and whether it's affecting any other structures in the mediastinum. And then MRI is great, especially looking at soft tissue and whether there's any invasion into the chest wall or any of the other structures we have there. And we have PET scans, that's going to look for like malignancy that has metastasized into either lymph nodes or anywhere else in the body. All right, let's go over some chest x-rays. So everybody remember how we evaluate these. We use our ABC mnemonic for this, and we'll go through it. But it's important that we consider the chest x-ray and basically which one are we taking. So there's going to be different ones we're going to talk about in block 3 for trauma. So typically here we're talking about PA and the lateral film, but we also have AP films, which we have to differentiate from the beginning which one we're looking at. It's important, and we'll talk about why in a moment. But you also want to make sure you got the right patient and that you're looking at. And I know I said it already, but if you order any sort of imaging, make sure you guys are actually evaluating your images, not just reading the reports on them. It's really important. Sometimes things can be missed, but it's also great practice as well for you guys when you're out there. All right, so starting with A, we're looking at air, looking for any airspace disease. And typically this is going to show up as usually fluffy, cloud-like, hazy. It's going to, basically you have the dark lung in the background, so any sort of disease in there is going to light up, and typically will be a whiter color. We can also have interstitial lung disease, which are usually smaller particles. And this is typically from fibrosed lung tissue. And so you'll see some honeycombing, and that can be associated with different disease processes. Next, we're going to look at the bones, which the bones can be very tricky to look at on your film. So we have a really good x-ray right there. That's why it's from the textbook. But a lot of times, depending on the pathology, we may not be able to get that sort of shot on the patient, so they might be rotated a little bit. It's important that we look at the bones, we assess, luckily we have two sides to compare them to. And then we're just looking for symmetry, any fractures. If they're rotated at all, it can be very difficult to assess a lot of those, like the sternal junction there. So we always have to keep that in mind when we're looking at it and make sure they're not rotated in any way, because it could throw off our images. You can also commonly see, like in the soft tissue right outside the ribs, we commonly can see subcutaneous air, which we call subcutaneous emphysema. So that can be a small indication that there might be more going on. So, like we're going to talk about pneumothoraxes and things like that. Well, it sounds easy on the x-rays we show you because they're usually very large. Well, a lot of times they can be very subtle as well. And sometimes the only indication you may see is that subcutaneous air, so that can help guide you in, like, okay, there might be some underlying trauma there, and I need to take a better look at this film, which we'll show some pictures here shortly. But it's a good subtle indicator that we need to look at. And then obviously we look at our cardiothoracic ratio, which is usually less than 50%. However, like I was saying, depending on the film, so for trauma, we typically get an AP film, so it's going anterior to posterior. So sometimes your cardiothoracic ratio is a little bit larger, and it's hard to evaluate on those. And if you can think about it, like the way you're standing there, the picture, the actual photos taken looking this direction. So if your heart's closer to it, it's going to look larger, depending on whether it's anterior versus a posterior film. So it's important to recognize that at the beginning, what you're looking for, or which type of film you have. Next, we're going to look for any density. So the lung normally appears dark or black, and then it becomes whiter when anything is substituted with for air. So a lot of these pathologies we're going to talk about with the pneumonias, we'll talk about pleural effusions and different causes. So a lot of times they'll light up, and they'll be a little bit whiter on there. Next, we're going to look at our diaphragm. So our right hemidiaphragm is typically a little bit more elevated than our left. And then we also want to check like those costophrenic angles on there as well. Just because, any blunting of that, we can sometimes get a pleural effusion, which is what we're going to talk about mostly in this lecture. But something to consider is it takes 300 milliliters of fluid to actually blunt that costophrenic angle. So on an upright film, they may have to have quite a bit of fluid there for you to even see it on it. Next, we look at foreign bodies. So we want to, and not just anything abnormal that randomly isn't supposed to be in the chest, but especially when we're looking at the studies or any interventions we've done. So if they have like an ET tube in, we want to make sure it's going down to the carina, it's not in the right main stem. If we've put it like an NG tube in, we want to make sure it's going into the stomach. We also want to look at our great vessels and our gastric bubbles. So you typically do have the gastric bubble there on the left. And then when we're looking at the great vessels, we normally have our aortic knob. We also have our ascending aorta on the right, which usually shouldn't cross that right heart border. If it does, we typically say it's a little bit enlarged. And then we obviously want to look at our hyla and mediastinum, and then we want to give our overall impression of what we think of this film. All right, so let's talk about pleural effusion. So this is fluid in that pleural space I was talking about. Typically, you got like 3 to 5 mLs of fluid in there. To see it on the x-ray, it takes up to 300 to even be visible, depending on the patient, if it's an upright film. So any fluid in the chest is what we call pleural effusion. If you have quite a bit, it makes that meniscus because you have that pleural lining all the way around the thoracic cavity and your lung. So you have fluid kind of dissecting into there, and that's going to create that meniscus appearance. And typically the treatment we do for this is we're going to do thoracentesis, which is basically sticking a needle in and draining it, or a catheter in there. And depending on what we think the fluid is, we may have to use a larger tube, like a chest tube, or we may just have to use something that we call a pigtail, which is just a smaller catheter we place in there. All right. What do we call it if the fluid in there is pus? Empyema, what you guys said? All right, good. And then theoretically, if you were to lay the patient down, that fluid in a right lateral decubitus view you should be able to evaluate it a little bit better, but I've never gotten a lateral decubitus film. I've never seen one other than a textbook, but it is something you can think about if you're unsure. All right, so now we got pulmonary edema on the right, and this is basically fluid just leaking from your blood vessels. Typically we'll see this in heart failure patients, and really, like we were talking about what causes the different conditions for like a pleural effusion, so sometimes we can get that increase in hydrostatic pressure like from heart failure, and it creates that kind of fluffiness in the lungs that we see there, and you should see it equally on both sides with a pulmonary edema. And then, you'll see what we call cephalization, which is an outward and upward appearance just because of your lungs and the way they're designed. So you'll see them moving from that upward direction, obviously because you have the apex of your lungs. But on the right, you got the perihilar infiltrates bilaterally, and then on the left, we can also get cavitation, which typically from some sort of lung mass, a lot of times we associate it with tuberculosis is a very common one we think about. But other fungal infections can cause this as well, and pneumonias, which we'll talk about later in the lecture when we have abscesses and other conditions that will cause this. All right, and then pneumothorax. So obviously this is air in that pleural space. And you can see on the left, the chest X-ray on the left, that left lung is a lot darker than the right lung. So, and you can obviously see that visceral pleural line there, where the lung is supposed to be. The film on the right side has a little bit more subtle pneumothorax. So we put that little black line on there, but typically you'll see a white line, and we call it visceral pleural line. When we have small pneumothoraxes, you'll sometimes only see it at the apex, and because you have those other structures there, like your ribs in the way in your clavicle, so sometimes it can be very subtle and hard to see those. So it's important we really evaluate that section of the lung, especially if we're considering a pneumothorax. All right, so this one's a diaphragmatic hernia here, and this is basically, abdominal contents have moved into the lungs. So, and on this, you can see the mediastinum shifted. This is from a ruptured diaphragm. That looks like, obviously, a baby X-ray or, a small child on that. So you have the stomach that's typically filled with air, and then it herniates into the abdomen, or into the lung, and that's what we call diaphragmatic hernia. And we typically do an NG tube for treatment until they can get to surgery, and that can help alleviate some of their symptoms as well and decompress it. All right, and then we have atelectasis. So this usually causes a density in the lungs because we don't have air adequately filling that portion of the lungs. And so then the alveoli the air gets resorbed, and then the alveoli collapse, and it kind of pulls the lung tissue, the lobe of the lung, and it creates this white appearance we see. And sometimes we can only see it along the fissures there between the lungs. So you have you have a displacement there. So sometimes it might be subtle, and that's your only sign. This is commonly seen in like our hospitalized patients or post-op patients because they're usually in a lot of pain, and so they're not taking deep breaths. So a lot of times we use the spirometer every hour in their room and force them to take deep breaths, and we can measure it so that we can avoid this type of condition. Now we have cardiomegaly, and then this can sometimes be confused with the pericardial effusion, which we have on the right. That's the one that looks more like that water balloon, filled with water, and the fluid is localized to a certain area of the heart, whereas cardiomegaly, it typically looks more equal throughout the picture on there. Now, obviously, the cardiothoracic silhouette's going to be over 50%, which this one looks, a lot more than 50% on there. And then you may have, like, your PMI might be displaced, and you might have some other findings. For an effusion, an easy way to do this at the bedside is we can actually use the ultrasound machine. And that's a better test we can use to evaluate whether it's an effusion or if we think it's, versus a cardiomegaly. So there are some tests we can do that are simple at the bedside to confirm. All right, so let's talk about some of the diseases here. So obviously we have some that we have benign ones and we have malignant ones, and we'll get into different processes here, but typically, for a lot of these, you'll have some sort of systemic illness with it, like when we're talking about pneumonias. Our history is going to be very important, whether they have any history of heart failure, whether they have any sort of liver disease. But the most common problem we see here is pneumothorax, just because obviously it's usually related to trauma, and we see it quite frequently, obviously with trauma, car accidents, any sort of penetrating wounds. So it is the most common one that we typically see, and it's usually easy to diagnose and treat. But what we're going to talk about mostly is some pleural effusions, and we'll talk about the different ones we can have. And this is important because sometimes we don't know what that fluid is. So we'll talk about how we're going to diagnose that and how we're going to draw it and what sort of different conditions can cause it. So whether it's blood, pus, chyle, air. Then we'll talk about some of the tumors that we have as well. But obviously the most common symptom you're going to have is they'll have some sort of chest pain and shortness of breath. And then usually it's worsened with inspiration or respiratory movements. And then obviously we have all of those different nerves that run, most of them run under our ribs. And then, so any sort of chest wall abnormality, malignancy, they can also cause, you can also have some chest wall pain as well. It's referred there. All right, so pneumothorax, so we have simple versus tension. So a simple pneumothorax is just a collapsed lung, but they have stable vital signs. And usually, depending on, and we'll talk about different sizes, but whether we consider it large versus small, typically anything over 30%, we're going to have to do some sort of chest tube for. So we'll do a thoracostomy. And then if there's any tension physiology, that's more of an emergent condition and needs treatment right now. So tension physiology will show obviously your vital signs, so they'll start to show some sort of instability, whether that's hypotensive, tachycardic, tachypneic. And then on your imaging, you might have shifting of the mediastinum. You could have tracheal deviation to the opposite side. Open pneumothorax, like I said, any sort of penetrating chest wound is called an open pneumothorax. Sometimes people call it a sucking chest wound. And then you can have a closed pneumothorax from blood trauma. We can also have spontaneous pneumothorax, which we'll talk about. I'm sure you guys remember from all the testing, like that tall, thin male, we typically think of a spontaneous pneumothorax with. But here's some of the different causes. So, spontaneous, typically, associated with smokers, anybody that has that thin build, marfanoid looking. Then we associate it with like COPD as well, and emphysema, blebs. And a ruptured bleb, which is usually the most common cause of a spontaneous pneumothorax, is a ruptured bleb. Most of the patients will present with some form of coughing prior to a spontaneous pneumothorax. So a lot of times they'll have an upper respiratory infection. I think and it's funny we say, this tall, thin male. My last spontaneous pneumothorax was like a 4'11" Asian woman. She had a URI for like the last 5 days, but not a typical patient. I definitely was not suspecting pneumothorax. I was just suspecting pneumonia. But, so, you obviously don't want to assume anything on your patients, but typically we say the tall, thin males. It can happen with anybody, and typically from coughing and a ruptured bleb. And we can obviously have it with trauma as well. All right, so clinical presentation, and that obviously varies depending on how severe it is. They may only have pleuritic chest pain, shortness of breath, or if they have like a tension pneumothorax or severe underlying disease, they'll typically have like a diaphoresis, they might be cyanotic, tachycardic, hypotensive. So that's more of an emergent condition that we need to treat right now. And it is a clinical diagnosis. We don't need a chest x-ray for it if we obviously suspect pneumothorax, like on physical exam. But you could have decreased breath sounds. That's probably the most common physical exam finding I see is decreased breath sounds on that side. And typically, depending on the size of it, most commonly at the apex of the lung, so it's always important we evaluate that when we're examining our patients. But you might have hyperresonance, and supposing you've done vocal frondus since PA school, you might have that too. So we'll talk about, for these, on block 3, we're going to talk about trauma and emergent conditions, and we'll talk about, stable, unstable. We'll get a lot more into pneumothoraxes, but other tests we can do, like, we do an ABG on them, and we might see some hypoxia or hypocapnia from hyperventilation. Well, a lot of times we get an EKG because they're presenting with chest pain, so we want to make sure they're not having a STEMI or any ischemia. And then we typically do a chest x-ray. So a CT scan sometimes is necessary to evaluate the extent, especially in a stable patient with a small pneumothorax. You want to evaluate how large it might be, and a CT scan is a better test for that. All right, so like I said, simple, typically simpler considered less than 30%. And if they're asymptomatic, a lot of times we'll monitor them for a simple small pneumothorax. And then, we may or may not have been in the hospital. If they have any hypoxia, we'll give them oxygen. And then we just follow them until resolution. Usually if it's over 30% or they're symptomatic, then we need to put a chest tube in that. So that's a thoracostomy tube, and we'll talk about that procedure here as well. If there's any tension physiology, we need to get a chest tube in there. That's the definitive treatment. Needle decompression is only a temporizing measure, and typically in the hospital, we're going to go right to a chest tube. So that's going to be your answer. If you're in the hospital setting, we typically always do a chest tube. Sometimes we can do a finger thoracostomy as well until we can place a chest tube. But a lot of times we're not doing needle decompression if we have the capability to put a chest tube in. But it is something, obviously, we do a lot with like tactical combat casualty care and on the battlefield. All right, so open pneumothorax, we typically want to put a one-way valve on there, and we have a lot of great dressings now with chest seals and one-way valves built into them that we can use too. But you can also do field expedient methods with just any piece of plastic and taping around it. And some, you can take 3 sides of it. And we'll talk about pleurodesis here in a little bit in the following slides. But here's a question for you. So which film is going to be the best for a suspected pneumothorax? Three? Yeah. So 3. Yeah, the PA film is a better film for it. It's nice if we can get a lateral too. And typically, we take the film on expiration. So this can be different from a lot of other conditions when we haven't taken, they might be taking they might have an inspiratory film. So it's important, if we can get an expiratory film, that's great. When we're in block 3, a lot of times all you ever get is an AP film because you can't take the patient to an imaging room and have them stand up for a supine film. So a lot of times we'll be diagnosing this on AP films, but if we can, we'd like to get a PA film taken on expiration. All right, so pleural effusion versus infiltrate. So do you guys understand this difference here between this? Have you guys covered this before? So this can sometimes be tricky. So an infiltrate is when we have fluid in the lungs, and a lot of times that'll show up like a pneumonia on our chest x-ray where it's fluffy in that one area of the lung, depending on which, like a lobar pneumonia, which portion of the lung. Whereas an effusion is fluid in that pleural space. So it's that lining of the chest wall is what we find with an effusion, and that just means your lung should be normal. So you should have a normal lung and your lung tissue is normal, versus the pneumonia, which is you basically have fluid or pus in those airways, versus your effusion, which is actually the pleural lining on the chest wall. And then we'll talk about the criteria for transudates versus exudates. But a transudate is just serous fluid. So it's usually like a clear serous fluid, typically from some sort of overpressure. So we have that increased hydrostatic pressure, and it's basically leaking mostly water or watery-like fluid into that pleural space. So that's what we call a transudate. So it's important we differentiate these because there's different treatments. One is more of a treatment for infection versus the other one is a treatment for the underlying condition like heart failure. And you can also see it with like cirrhotics or any sort of hypoalbuminemic conditions like any sort of kidney failure. There are some like protein losing enteropathies that can cause it, which we won't talk about. But we need to ensure it's not an exudate. And so the way we do this is we drop fluid from that effusion, and we have to send it for a sample. And depending on the parameters there, so when you have inflammation, which is typically from an infection, you're going to have more of, you're going to have a higher protein content in there because of the inflammation. You're going to be leaking protein into the pleural space versus with your transidate is mostly water from increased pressure or decreased osmotic pressure. But the most common cause of an exudative pleural effusion is malignancy. So it is something we need to consider. And typically, and we'll talk about the measurements, but we really measure the protein concentration, and then we look at lactate dehydrogenase concentration as well. All right, so here's some good x-rays that we have some infiltrates there. And we can kind of see the difference. It doesn't look like that meniscus fluid like we see with a pleural effusion. And then we'll show some other x-rays here too, but a lot of times we see this with edema, like when we have heart failure. So you basically just have that serous fluid leaking into the lungs, and you typically see it bilaterally like we do on the films here. There's a lot of causes for infiltrates and consolidation, obviously pneumonia, any sort of pulmonary contusion, which we see a lot with trauma. It's one of the more common injuries we see. Then obviously any inhalation injuries, sepsis. And we'll talk about trolley and some of those other ones in block 3. All right, so how do we figure out what's going on here? So we have a pleural effusion, so first we can get a little bit, hopefully from our history, if the patient's able to talk to us on whether they have any history of heart failure, so then we can, ascertain that it's, could be from some sort of over hydrostatic pressure causing this. Now, if we have that decreased colloid oncotic pressure, that could be from obviously your cirrhotics, your hypoproteinemia, your renal failure patients. So history is important to help us differentiate. And then, like I said, we can have an inflammation, which causes obviously an increase in that capillary permeability. So that's any inflammation is going to cause that increase in permeability, and then you're going to have vasodilation. So it basically becomes a lot more leaky, and we see that with lots of different infections, pancreatitis, sepsis, and then if we have that decrease in interpleural pressure, we can see atelectasis. And then there are some conditions where we have lymphatic drainage in there, a decrease. So we'll talk about a chylothorax and some of the other causes. Some of these causes are actually, when we say traumatic injury, it's actually us that causes it. It's iatrogenic. So a lot of times we place a central line and we do it in the subclavian here. So it runs a risk of damaging our ducts and also causing pneumothorax as well. So, we do iatrogenically cause these frequently, which is why we like to get chest x-ray after every central line. All right, so what's the clinical presentation going to look like? It's typically going to have some chest pain, shortness of breath. Some of it depends on their underlying condition. On your physical exam, you might hear a pleural friction rub. You should hear some decreased breath sounds, dullness to percussion. Depending on where it's located and how long they've had it, you might have some actual localized tenderness over that area as well. And then we obviously want to get a chest x-ray, and as you can see on there, that's quite a bit of fluid in there. It takes at least 300 before we see it, and your lung can hold like 2 to 2.5 liters of fluid in there. So if it's large enough, it can cause the mediastinum to shift as well and create almost like a tension physiology, depending on how large it is. If we need further evaluation, we'd like to get a CT scan for these, and this can just look for any loculations, any sort of complex fluid pockets that we might see in there, or if the diagnosis is in question, a lot of times we'll order a CT scan for better evaluation. And then, if it's something that can't be treated But in the office there, then, or in the ER, we may have to go to interventional radiology if your hospital has it. So this is a great service that we use a lot, and so they're a great option for doing drainages on these, and they have a little bit better equipment, and most of it's done under IR vision, and you know, it avoids any complications. So if we have an option, we like to do it. It's not something we can do, you know, in the surgical suite or in the emergency room. All right, so for diagnosis, we need to actually draw that fluid, so we're going to need to place something in there, whether that's a needle versus a catheter that can stay in place, and that's going to depend on how large that fluid collection is. So we're going to draw the fluid off there, so we'll do a thoracentesis, and it typically requires 20 milliliters of fluid. If we can, we like to drain all of the fluid out of there, especially for symptomatic treatment. It's helpful. So to differentiate whether it's the transudate versus exudate, we have to look at the protein concentration, lactate dehydrogenase, and then we'll get the glucose and a gram stain culture as well to see if there's any bacteria on there. But it's important we recognize the different concentrations we have. So with the transudate, it's typically going to not have a lot of protein in it, and your LDH is going to be low as well. And the spec Brad's typically below 1.016. And this is because it's not an infection. So obviously, with an infection, we have a lot more protein leaking. Lactate dehydrogenase is obviously involved in all the cells in our body. So if we have any sort of infection, we'll have an increase in our lactate dehydrogenase, and that'll be what's noted on our thoracentesis. So this helps us differentiate whether we think it's an infection. So if it comes back like positive on the gram staining culture, then we know it's more of an exudate or an infection, and it'll guide our treatment. And then, like I said, it's like over a quarter are from cancer. So when we see a pleural effusion, if we're unsure if it's, you know, they're not like a young healthy patient with an infection, we need to consider cancer for these patients. So typically, all patients with a pleural effusion, we're considering cancer or malignancy for the cause. But here's the procedure. So we can do it at the bedside. It's best if they're able to sit up like that, but some patients aren't, so we may have to roll them onto their side, depending. But then your fluid is going to shift. So, you know, our best method is having them sit there, resting usually on the little Mayo part next to the bed on a pillow. And then we just need to identify the site. Nowadays, we use a lot of ultrasound, so we can actually identify exactly where that fluid pocket is with the ultrasound machine. And then we need to anesthetize the area, typically just with some lidocaine. We'll do some local anesthetic there. And then we just place a needle in, applying negative pressure until we hit that fluid pocket. And then, like I said, we need at least 20 mils if we're going to run a sample from it. A lot of times we may place what we call a pigtail catheter, which is just a small plastic catheter that's guided over the needle in a wire. And then we can leave it in the chest and continue to drop fluid off of it if we need to while they're in the hospital for their stay. And then obviously we need to get a post-procedure chest x-ray on all these patients. All right, so here's like a tube thoracostomy. So this is going to be something that requires a larger tube. You can see on the picture there, that's more what we call like a pigtail catheter. Typically 18 French or smaller is what we use for those. And if we're doing the tube, then we'll make a little bit larger incision and place a chest tube in there, usually on suction. And that's for drawing a lot of fluid off the patient. So we'll typically leave those in there until the lung can re-expand, and we can drain those fluids typically over the next 24 to 48 hours. All right, so what's the treatment? So it depends on what's causing it. Since we said the malignancies, over a quarter of the cause of these, we basically want to search for whether it's like a primary like lung cancer causing this, or whether it's some sort of seeding from somewhere else on these. So Sometimes all we can do for malignant ones are strictly palliative, especially if it's a metastasis from somewhere else. A lot of times we don't have great treatment. It usually portends a poor outcome on them as well. And then when we talk about pleurodesis, this is basically, so once our lung re-expands, we have a very high recurrence rate of it causing another effusion. So what a pleurodesis is basically we take some sort of material, typically talc is the most common one, and we irritate the pleural lining and cause inflammation, and that helps actually tack the chest wall down. So these patients a lot of times will require a pleurodesis afterwards so that we can keep their lungs completely filled. And then we'll talk about thoracic empyemas here shortly in the slides, but once again, obviously thoracentesis is our procedure, how we're diagnosing all of these. And basically, depending on how much fluid is in there, we're deciding what size tube we may need to place into that area. Then obviously hemothoraces, these are typically secondary to trauma, and we place a larger chest tube in there, which is a 36 French, which is pretty large. Then we can also have lymphatic fluid in there, which is typically from chyle. And this is this can be caused iatrogenically, but we can also have lesions in our lung that can also have like a space occupying effect on that area and cause it too. For these patients, we control them typically with their diet, so we place them on like a low-fat, medium-chain triglyceride diet. That often reduces the flow of the chyle. All right, and then pleurodesis, like I was just talking about, so as you can see, they have a camera in there, and they're basically, the most common thing we use is talc, and it's a sclerosant agent, and it causes inflammation and irritation in that area, and that helps reestablish that pleural space and attacks it to the wall, so that they can actually, we can prevent recurrence, and it also helps with expansion of their lung as well. But we also use doxycycline too. Talc's been, it's the least expensive and it's been around forever, so it's the more commonly used one. All right. Which of the following conditions is not associated with a transudative pleural effusion? Malignancy. So yeah, the other conditions in there, obviously, CHF causes that increase in the hydrostatic pressure. Nephrotic syndrome can cause like a decrease in the colloid pressure. And we have myxedema as well. But typically a transudate is going to have like your total protein content less than 3 and your LDH less than 200. Then a thoracic empyema. So this is basically, pus accumulates within that pleural cavity. We also call it biothorax. What we need to, in order to evaluate this, we need to figure out what's causing it. So the best way is to draw that fluid off there and evaluate it. So these are typically from like multibacterial infections. Staph is the most common organism, but like it says on the bottom, we typically isolate more than one bacteria species per patient. So we typically provide broad coverage with this. We also want to cover for our gram-negatives as well. We can see these with like Klebsiella pneumonia too. So you can also get these from like an aspiration pneumonia. And then obviously our funguses, some of those rare funguses you might see it with as well, depending on if you're in the right area. All right, so there's a natural history to the empyemas. So, it starts with an acute exudative period, typically within the first couple days. And the difficult part diagnosing this is it's still a pretty low viscosity, and we don't see a lot of that, a lot of that protein from the inflammation yet. So our fluid can still be a little bit serous. However, it does start to evolve into like the fibrinopurulin phase. And this is when we just have fibrin is deposited in the pleural spaces. And this is when we start to see like an increased turbidity. We'll have a white blood cell count in the fluid, and the LDH levels start to increase as well. And then at this point, we start to get a decrease in the glucose and the pH. And then it's followed by the chronic organizing phase. which is typically when our pleural fluid has a glucose of less than 40, pH less than 7. And then we tend to see those fibrin deposits thickening. Oh, wrong button. All right, so once again, these ones tend to present similar symptoms. They'll have the chest pain, they'll have the dyspnea. They'll typically have a fever with this as well. They may or may not have hemoptysis. They typically have a productive cough. Then we can see other symptoms with it as well, and that can be related to some of the underlying disease that they may have, whether you might see an anemia with it, tachycardia, tachypnea, depending on how large it is, diminished breath sounds and dullness. And then, depending on the underlying pathology, you might have like cluttering of the fingertips. And they talk about like a pulmonary osteoarthropathy, and that's typically from some, that can be congenital or from some other kind of increase in the pulmonary vasculature pressure, like you would see with heart failure as well. So we get a chest x-ray on all these patients, and then we might see underlying pneumonia, there may be a lung abscess, pleural effusion. You can see these D-shaped densities on that chest x-ray, and in large ones you may have a shifting of the mediastinum or that like tension-like physiology you would see with the pneumothorax. However, it's obviously fluid at this point. These patients all need a bronchoscopy, so we just need to look for any sort of obstruction. And then we get a CT scan on them, and this can help us differentiate. Sometimes it's hard to tell whether it's a lung abscess versus an effusion. And then we need to get a thoracentesis and run the fluid sample on these patients. These ones typically have that elevated protein by this point, and they will be exudative. All right, so what's the treatment for these? So it's typically from an infection, so we need to cover them with broad spectrum antibiotics. We need to remove that fluid from the lungs, and it's kind of like an abscess on the skin. So, I mean, you guys have had derm, or you're taking derm right now, right? No, not yet? Okay. Well, an abscess is an infection, obviously. It's a walled-off pocket of bacteria or pus, and sometimes we'll see providers prescribe antibiotics for it, but really by that point it's walled off, and you've got that localized area of bacteria, so the only way to treat that abscess is to drain it. And it's similar here for the lung, so we have to remove that purulent material or that bacteria, and then we have to re-expand the lung, and then we want to evaluate what the underlying process may be, whether it was infection, whether it's malignancy, which is why we run those, why we do the, run that thoracentesis sample for these. But the initial treatment is going to be your tube thoracostomy, and then we typically leave it in during the hospital stay and monitor them with the CT scans or serial chest x-rays. And then if it's severe, they can do open drainage for it. But that normally requires a little bit more invasive procedure. They have to go to the OR for that one. So that's typically if the other measures fail, we would do that. All right, let's take a 10-minute break. I know it's Friday, you guys want to get out of here. You guys are going to like to start shutting your computer screens in a second, I know. All right, so we'll talk about lung abscess next. And this is typically begins as necrotizing pneumonia. And it causes just liquefactive necrosis of the lung parenchyma. And then we categorize it whether it was primary or secondary. And typically primary is in a healthy individual, and secondary is due to an underlying cause. A lot of times it can be a malignancy. The most common cause of primary lung abscess is going to be your aspiration pneumonias. So, and this is something we can see with like even our hospitalized patients, why we like to place an NG tube in them depending on the procedure they're getting, or whether we're putting them under for any sort of anesthesia. Or we see this a lot of times, if everybody remembers, like in those alcoholic patients, we tend to see aspiration pneumonia as well. And that one, like for like board questions, was always associated with like Klebsiella pneumonia, if you guys remember that, or if they taught that already. But secondary is going to be usually from some sort of tumor or some sort of bronchial obstruction. And then they can have like AIDS patients with an opportunistic infection, that would be a secondary. cause as well, like with our PCP pneumonia. All right, and like the other conditions, they're all going to have pretty similar symptoms with these. So fever, cough, putrid sputum, hemoptysis, shortness of breath, like pleuritic chest pain. They may have weight loss depending on the underlying condition. And then they'll have some sort of signs of like lobar consolidation, so it looks like a lobar pneumonia. However, we have that like air pocket in there, like air fluid level, that we typically see when it's necrotizing. And then you can also have like clubbing, signs of pleural effusion. If it's malignancy, a lot of times it'll be cachectic. And then we obviously want to run like our normal laboratory studies. We want to get a CBC on them and look at their white count. These are ones if we're suspecting some sort of infectious process, we want to get a sputum culture on them. And then chest x-ray is very helpful. And then if we can get a CT scan to differentiate, because sometimes you can't see the abscess on the chest x-ray. So a lot of times you look at a CT scan with these patients. All right, so first line therapy and the mainstay of treatment is going to be infectious. So we're going to get antibiotics here. And the difference from like your normal pneumonia, you treat, nowadays we do 5 days for just acquired pneumonia. The kids will do a little bit longer. But for these ones, we typically start with 4 to 6 weeks, and it can sometimes get up to 12 weeks of therapy for these. So we'll start with our antibiotics, and then if there's no response, then we look at other options like draining that area or the abscess, so we can do a percutaneous drainage. And sometimes it can take 3 to 5 months for these patients to completely resolve. So what we like to do in the meantime is what we call chest physiotherapy, which is basically, we have different devices we can do for it, but it's basically just percussing the chest and getting that fluid movement in the lungs. Actually help these patients out a lot. So, and we do have little devices that do the same thing, and they just kind of create like a vibration on the chest to help drain all of these. But these are important measures we use, especially in the hospital. We have a lot of different chest physiotherapy devices we can rely on. And a lot of times we'll get our respiratory techs involved with these patients as well. So operative intervention, obviously, if failure of treatment, we don't see any radiologic improvement. And this one, it depends on the extent and the location, but they can, we may do like a VATS procedure, thoracoscopic, versus like an open lobectomy on these patients. All right, here's just some pictures of an empyema versus a pneumonia versus an abscess. Did you guys see that air fluid level in the right there? We have obviously that density there. It looks like similar to a consolidation or a mass. And then it has that air pocket in it, which is typical of an abscess, versus you have that middle picture of a pneumonia, and you can see the consolidation there in the lung. And then we have the empyema, which is more in the pleural space and on the chest wall. So that's, chest x-ray is a great way to differentiate. Sometimes, since the empyema can sometimes look like the abscess, depending on the location, we may get a CT scan to help us differentiate these. All right, let's talk about some lung cancer. So it still is the most common cause of cancer-related death in the United States, and it has been for a long time. Even though we've decreased, tobacco smoking significantly, now it's replaced with vaping. And we haven't seen the full effects of that yet, but typically we associate lung cancer with smoking. 85% are from smokers, and they still do have a risk, depending on how long they've been smoking, for the rest of their life. Sometimes they say after 15 years it decreases. The risk declines, but they're never going to reach the same risk they had prior to smoking. So you can also have an increased risk from passive exposure, so secondhand smoke. Anybody else in the house smokes. And then obviously asbestos is one we always are worried about. We all probably are going to get this from this building. It's so old. But that's like your mesothelioma, and I don't know if you still have commercials now. It used to be on commercials all the time. And then historically, we talk about like, shipyard workers, cement makers, things like that. But functionally, we separate our lung cancers into non-small cell versus small cell are the two most common differentiators we use. And non-small cell is typically 80% of the cases we see. And some of the ways that we look at it for differentiation is where that infection is, whether it's central versus, not infection, but where that malignancy is, whether it's central versus peripheral in the lung, and we see common ones in certain areas. So like your small cells typically going to be central, while your adenocarcinoma is going to be more peripheral. And we'll look at some of these lesions here and talk about the treatments in the following slides. So we obviously are going to have some sort of mass in our lung, so we will likely have some local effects from it. So like central tumors are going to cause your cough, hemoptysis, they're going to have that chest pain. They may have a history of pneumonia. And then for the more peripheral tumors, we might just see chest wall pain since it's localized more in the outer lung. They may have pain along the chest wall. They usually have the cough as well. And then they may have pleural effusion and abscess. We do want to differentiate because we do see certain syndromes associated with different tumors. So like our peripheral tumors, we'll see that Horner syndrome, and everybody remember what that is. That's the meiosis, ptosis, anhidrosis. So, you'll see that pinpoint pupil on one side. You'll have that droopy eyelid, and then you'll have no perspiration on that side. I've never had a patient complain of not like sweating on one side of the face. Typically, probably because it's more elderly patients we see this in. I feel like I would notice if I was running and only half my face was sweating, but maybe not. They're probably not running at this point anyway. We can also get mass effect from like our Pancoast tumors, and we call it Pancoast syndromes. That's typically more in the apex of the lung, and they're going to have some sort of compressive effect, and that's going to start to compress on some of those nerves we have there, so they may complain of a shoulder pain with that one. And that's typically associated with like our superior sulcus tumors, and it's usually squamous cell for that one. And obviously these can have symptoms due to the regional spread too, so there's a lot of nerves that run through that area in our mediastinum, so we can get that hoarseness if it's the recurrent laryngeal nerve. If it's the phrenic nerve, they might have shortness of breath. If it's, impinging on the esophagus, they can have dysphagia. And then obviously we have our superior vena cava as well, and if they have compression of that, you can see some different symptoms, which we'll talk about here shortly on those symptoms. And typically that's like a unilateral facial swelling worse with laying down. But, most of these patients will have those like constitutional symptoms of like anorexia, weight loss, fever, weakness, malaise. And then it all depends on if there's any metastases for these. The issue is a lot of these go asymptomatic for a long time, so they can have metastases distant from here. And it just depends on where that metastasis is and what symptoms they're going to have with it, whether it went to the brain or the belly, in the bones. All right. So obviously the presentation is going to be based on location and whether we have any sort of mass effect for these. So central ones typically are touching the bronchus, so they can have that cough and hemoptysis. If it's more peripheral, they may have that chest wall pain, and then they can have that sulcus tumor, which you get that Horner syndrome and the Pancoast syndrome. You might see an atelectasis on your films, and then sometimes, or a lot of times, it'll be asymptomatic. So we'll talk about the lesions here that we evaluate and what our time frames are, because a lot of times we'll find pulmonary nodules in, patient. I'm sure a bunch of us have it in the room here, and we monitor those to see whether they become bleeding or not. All right, so we do have paraneoplastic syndromes that are associated with these different types of cancer. So we have like our carcinoid syndrome, which typically is a small cell and carcinoid tumors, and then we have like SIADH, which we tend to see with small cell lung cancer, and then we can also have like our hypertrophic pulmonary osteoarthropathy, which we see with all of our non-small cell cancers. So here are some of the syndromes we might see with it, like with non-small cell lung cancer. we might see a hypercalcemia with these patients. So a lot of times he'll be asymptomatic, and we may note this on just a routine laboratory evaluation. And this can be a sign of metastasis to the bone, or sometimes a tumor can produce like a PTH-like substance as well. With our small cell lung cancer, we can have that SI-ADH, so they'll have that low serum sodium. You can have like melanocyte stimulating hormones, then get hyperpigmentation. And you can also see an ACTH production as well, so they'll have like a Cushing syndrome type appearance. And then many of the cancers metastasize to the adrenal glands, so you may see adrenal insufficiency, and that's like your fatigue, salt craving, weight loss, and then multiple electrolyte imbalances with it as well. So the Pancoast tumor, so as you can see, it's in that like superior sulcus of the lung there at the apex. And this cancer invades the chest wall, so then it creates impingement on different nerves. It can also affect the lymph chain and the superior vena cava as well. You can get ulnar compression, but this is when we see that Horner's triad, so the ptosis, meiosis, and anhidrosis. And typically this is with a squamous cell cancer in the lung apex. And in the SBC syndrome, you get the obstruction of your superior vena cava, and they have swelling to the face and arm. Typically worse when they lie down or bend over. All right, so how do we diagnose these? Typically, the first thing we get is the least invasive, and that's a chest x-ray. So we may see findings of just like a pulmonary nodule or a solitary pulmonary nodule. And then we look at whether it's peripheral versus central. We'll typically get a CT scan for all these patients, and we do get it with contrast. So it gives us a better evaluation of the extent and the location of the tumor and the size. And then also, if we also want to include the abdomen if we're worried about any sort of metastases. Serum alk phos is an important test as well. So this can be a sign of metastases, and that can help guide us to whether we need a bone scan or an MRI in these patients. And then we have like our PET scanning, which is a critical staging test, and this just looks for any sort of metastases throughout the body or any sort of distant occult disease that may have spread from the lung cancer. And then we can do a thoracentesis or a thoracoscopy for both. And this is obviously if we have pleural effusion, we need a thoracentesis. But sometimes we'll have to place a camera in there and evaluate and run a sample as well. All right, so here's kind of our differentiation here, and this is what you guys will see in clinic a lot. You'll get a solitary pulmonary nodule, and you'll have to decide, what our follow-up times are with those. Most of the time, if we see it on chest x-ray, we'll order a CT scan with contrast for further evaluation. And then we typically judge it by the size, so if they're less than 2 centimeters, we'll tend to evaluate them with serial CTs over the next 24 months. So typically they're like a year apart. And we just want to make sure there's concentric calcification, they have a smooth border, it's a solitary lesion, there's no speculation in there. If they're over 2 centimeters and we see any of those abnormal findings, like it's increasing or unstable in size, you have that speculated border, multiple lesions, or irregular calcifications, then we're more concerned for malignancy and we'll want to do a further evaluation, and that's typically CT scan and then possibly some sort of biopsy for further evaluation. We also do need to consider their symptomatology, obviously geographical location, because you can get those, histoplasmosis or coccidiomycosis that can also present with similar findings with these nodules. And they're not malignant, they're more infectious. So, what do we do for evaluation? So, the standard diagnostic modality is going to be a bronchoscopy, and that's typically going to be a lavage where we inject saline and we aspirate it out and send the sample. If we can get a deep cough for sputum analysis, we can, but a lot of times it's hard to get the adequate sample from just your sputum cytology from a cough. So most of the time we'll get a bronchoscopy, and then we may do a biopsy as well. There's also newer techniques like an endobronchial ultrasound, and then they can do a fine needle aspiration. So they're using just a small ultrasound probe down the esophagus into the bronchus, and then they can run a fine needle aspiration from that, and then it's just better guidance when you're taking a sample if you're using an ultrasound. So, less risk for damaging other structures, which is why we like to use that more frequently now. And then we can have a percutaneous or transthoracic biopsy, and a lot of that's going to be based on what our CT findings are and where the location is on which one we're going to do. And then you can do a wedge biopsy, which is done in the operating room, and you're taking a large portion of the lung. So that's typically one of our more invasive options. So we typically try for the other ones first before we go to that wedge biopsy. All right. So here are just some different terminology we have for neoplasms. Unresectable means it's in more an advanced stage and it's already invaded other structures. So we're not able to remove that lesion, and typically is going to be palliative therapy at that point, versus like our inoperable. So this is going to be like our comorbid patient, they might be unstable, and they're not a good candidate for an operation. So it's important we understand differentiation between those terms. And then what do we do if we are taking them to surgery? Obviously we do, like we said, our pre-op assessment like we talked about in the first block. But what's more important for this is evaluating their pulmonary capacity or pulmonary function. So we're going to do our typical normal factors depending on their comorbidities and what tests we're going to do. We're going to look at their age, whether they have any contraindications for resection. And elderly alone is not a great indication. Typically based on comorbidities. I treat a lot of elderly patients that are still very active, well into their 80s. So, it's not a complete contraindication. But we want to do a thorough cardiac evaluation. A lot of these patients will get a stress test irregardless of their symptoms. So especially in the elderly with these neoplasms, we'll a lot of times send them to the cardiologist. They'll get a stress test. If they have coronary artery disease or significant coronary artery disease, a lot of times they'll get a PCI during their evaluation just to assess the coronary arteries. So it is a little bit more invasive, and they do get a lot more testing when we're evaluating these patients on what their pre-op risk is going to be. And then they'll all get sent to the pulmonologist for a pulmonary function test. So they'll do spirometry. And then VQ scan, not very commonly used anymore, but that is an option if we're not able to do some of the other testing on them. So it is out there still. All right, so what's our treatment? It depends on the type of lung cancer, where it is, and what stage we have it in. But, we can start with conservative measures. That may be observation if we're not expecting malignancy. And then if we think there's any infection, we get antibiotics, steroids. If there's a pleural effusion, we'll do a thoracentesis. And then if we're excising, we can use VATS, so we can look at it through that video scope, and it's less invasive, as you can see on the right there, typically with the cameras, versus a thoracotomy is when we have to open the chest up. So it's a lot more invasive of a procedure. And as you can see, there's not a lot of space between our ribs, so we have to incise that area and then open it up with those spreaders to be able to operate on them. So it's a pretty significant procedure. And then depending on the size of the lesion and what stage they are, we may have to do some sort of neoadjuvant chemotherapy to shrink the tumor first versus adjuvant treatment. So it all depends on how far along or what stage they are. So with our T&M staging, which we'll look at here, you guys don't need to know the T&M staging for this. So that's not important. What's important is to understand how we stage tumors. So we want to look at the size. We obviously want to assess for any sort of lymph node involvement. Then we want to look for metastases. So this will be a pretty thorough evaluation, and they'll have to get lots of imaging for us to complete this, possibly followed by biopsies to assess for nodal involvement. All right, so a 62-year-old heavy smoker. He's got general malaise, occasional cough. 10-pound weight loss over 2 months. No recent travel or infections or any medication use. He does have borderline diabetes, control with diet. Exam shows a mild peripheral edema in the extremities and clubbing bilaterally. Blood work has a mild anemia and a sodium of 122. What test should be done next? Yeah, chest x-ray. That's a pretty easy one, right? If only the questions were this easy. All right, I know it's not funny, though. I wasn't laughing when I was in your shoes, so I can assure you. But, all right. What questions do you guys have? Come on, you gotta have some questions.
Sir, for the 3 stages of developing the
Yeah.
during the first stage, is it basically just like a sterile transbate and then because it's stagnant fluid it gets infected, or are the bacteria there like from the word go and it just gets worse?
They're usually there from the go, but they just aren't showing any signs of infection yet because it's so early. Just like with a lot of testing we do, like I test a lot of flu patients that their symptoms started today, a lot of them might be like a false negative, so it's similar to that. What are the questions? Yeah, just want to get out of here. Does anybody want to come talk to me in the office or review any